Hi, this is Kavanaugh, and I'm coming to you from RheumNow Live 2025. And this is a step talk. And the topic is the management of rheumatology patients, focusing on RA patients right now, and liver disease. So, a very important issue we deal with in the clinic a lot. As you see in the title slide here, that's a image of Prometheus. Prometheus was a titan, and he took fire from the gods and brought it to humans to give them knowledge and comfort. And as a result, the gods punished him, and they punished him by sending an eagle to attack him every day as he was tied up, and the eagle would eat his liver. And even the ancients knew that the liver was an organ that had impressive regenerative capacity. So as we talk about injuries to the liver, we remember that, and we do hope that we are able to control our rheumatologic diseases and also keep the liver happy. So here are my disclosures. We're going to talk about potential causes of liver dysfunction, things we're all going to see. Metabolic dysfunction, we'll talk about at the end a lot, metabolic syndrome. There are a number of toxins, alcohol, plants, herbs, sometimes patients get, and they can cause liver dysfunction. Infections, some we can screen for and prevent, some we can treat. The hepatitis B and C, but also EBV, CMP. Medications we'll talk about a good deal because we cause some liver problems. Now, in some cases, this is predictable. Acetaminophen is a toxin in a dose-dependent fashion will cause liver dysfunction. Others, tough to predict, idiosyncratic. The nonsteroidals, about 1 in 1,000 people will get an acute hepatic injury pattern on their liver function tests with the use of pretty much any nonsteroidal. The same with TNF inhibitors. We don't know the mechanism, but it's thankfully rare. In some cases, liver dysfunction is mechanistic. IL-6 inhibitors, for example, impair the function of liver cells and will cause an increase in liver function tests, although it's cyclic and it's dose-related, and it may not cause clinically evident hepatic injury. And then there are a variety of other medications. Our old friend methotrexate, well known to be a potential cause of liver dysfunction, as well as the JAK inhibitors, as well as leflunomide. Now, some people have a genetic risk, hemochromatosis, not so uncommon, that will predispose them to liver injury. There are some less common autoimmune diseases like autoimmune hepatitis, and celiac disease can have associated liver dysfunction. And then things apart from the liver, physical causes of liver dysfunction, such as congestive blockade of the bile ducts. So many things that can cause liver dysfunction, and we worry about it because injury begets inflammation and fibrosis, fibrosis being part of healing from an inflammatory or other injury. That can become severe. That can cause cirrhosis, at which point you have an elevated chance of hepatocellular cancer. Eventually, if your liver stops working, you can get to end-stage liver disease and death. We assess the liver all the time because the potential for our medications to cause liver injury. We check liver function tests. We check other things, the INR, which is a very good way to check the synthetic function of the liver. And also the plain urinalysis gives us an indication because you measure urobilinogen and bilirubin in the urine. The GI colleagues use something called the fibrosis 4 index, which incorporates age, the ALT and the AST and the platelet count, and that gives you a risk of advanced fibrosis in people, not those that are too young nor too old, but it gives an idea of what may be going on with the liver. These days, we can also image the liver. We can image it with ultrasound, and we can look at the fibrotic properties of the liver by using elastography. Now, a couple of things that we need to be aware of, the liver functions can be variable. They will go up and down depending on the food that you just ate or whether or not you're fasting. And remember that these causes are not always distinct, and sometimes they can contribute or they can have synergistic impact on liver function. Well, here we'll talk about RA treatment, but this talk obviously could go for many rheumatic diseases. And here you see the drugs that we commonly use. Why do we talk about liver disease? Because so many of them can be associated with potential hepatic adverse events. Here you see those that are not uncommon in the bold and the italics. Those in the italics are rarely associated. And what you notice is that there are not so many medications that seem to be really, really clean as concerning the potential for injury to the liver. So we're using a lot of medications. we have to be aware of the potential of causing hepatic damage. Methotrexate, our old friend, we've been using it for many decades now. We learned, actually, our dermatology colleagues who had used it more than we did back in the day for psoriasis in the 70s, they learned that intermittent dosing was better in terms of liver dysfunction. That begat the typical dosing regimen that we have now, using methotrexate on a weekly basis. So we've learned a lot about this. We've learned to watch for other contributors, such as ethanol. And I think we've learned to manage this, and we still use methotrexate, of course, very commonly in our patients, and use it safely. What about infections? Well, we know that hepatitis B and C, we particularly worry about in terms of hepatic function. We've come such a long way now. Now we can really screen quite well for exposure to hepatitis B, and we can measure the viral load, and we have treatments that can control hepatitis B. So we've seen these algorithms. We're familiar with these algorithms. We very typically test our patients before we give them biologic or targeted synthetic DMARDs, very commonly for these infectious causes, such as hepatitis B and as hepatitis C. So here you see we don't have a vaccine for hepatitis C as we do for hepatitis B, and making sure people have been vaccinated is a great idea for hepatitis B. We don't have one for hepatitis C, but very, very importantly, we can now cure more than 95% of patients who have hepatitis C with a combination of antiviral agents. Very, very exciting. Very different than what we had available to us in past years, that's for sure. A big change from our gastroenterology colleagues, particularly those with interest in the liver. So we used to talk about NASH, about non-alcoholic steatohepatitis. Well, that's old terminology. They don't use that anymore. They've changed to MASLD, metabolic dysfunction associated liver disease. Kind of take the word alcohol out of it. And it represents really more of the underlying predilection, and that is the metabolic syndrome. And here you see on the right-hand side the characteristics of the metabolic syndrome, and you need to have one of these to be diagnosed with MASLD. Very, very common in our patient population. In fact, MASLD is really the most common cause of liver disease throughout the world, and it's increasing in prevalence, certainly increasing in Western societies as obesity is increasing. And we know that that is a very strong risk factor, importantly, a potentially reversible risk factor, as we'll come back to. Very common and probably synergistic with some of the other causes like our medications. So I think the gastroenterologists are impressed with us. We're checking liver functions all the time because we have to make sure that the medications we're using to control the active systemic inflammatory rheumatologic disease are not being injurious to the liver. So here you see steatotic liver disease, MASL or metabolic associated steatotic liver, MASH, which was the same as NASH, metabolic dysfunction associated steatohepatitis. You see the potential for an interaction with alcohol. You may also put in there, for our standpoint, interaction with other medications. But this is kind of how the GI folks are thinking of MASLD these days. Very, very exciting times in that now there are therapies. Of course, we're very excited about the anti-diabetes, obesity controlling medications like the GLP-1 receptor agonists. They had some promising data, some really, really interesting data lately with the dual inhibitors. So you see on the right from a recently published article, tirzepatide, which is a dual inhibitor, a GLP-1 receptor agonist and a GIP receptor agonist. You know, these are the kind of data that people say you barely need statistics to look at these data and say, wow, this is really quite something. And this is, you think back, not very long ago, if someone had fatty liver, you'd say, well, gosh, too bad, you know, lose a bunch of weight, maybe get your diabetes under control, hopefully it gets better. Now we definitely have something that we can do. And there are other drugs. One is already approved, that's resmetirom, and there's others now being studied. So I think this is super exciting because we encounter MASLD, we encounter liver dysfunction in many of our treated patients. Now we have something that we can potentially do about that. Super exciting. So what would a step talk be without a acronym? And this is kind of a quick way that I think all of us as rheumatologists treating our patients with rheumatoid arthritis, with other systemic inflammatory autoimmune conditions, this is what we need to do. We got to think about it. Got to think that maybe there could be hepatic dysfunction, all the different potential causes, the ones back on that first slide, from the genetic predisposition to exogenous things like herbs to the medications we're using to, of course, MASLD. We assess liver function. We do that all the time. I know there are now medications used, for example, for skin psoriasis, where you don't need to check liver tests. In rheumatology, we're not afraid. We're not afraid of checking liver tests. We do it all the time. Now, I think we also pay more attention to assessing for comorbid conditions. What about the prevalence of the diabetes? Of course, obesity. And this is relatively simple. These are things we get from a good history, focused lab testing, and relevant imaging. So nothing so fancy. Fend off things that we can. Vaccination where appropriate, hepatitis B, for example, optimizing comorbid conditions. And now we see if we get the obesity drugs, that may be something that we incorporate more regularly into our therapeutic armamentarium to control the comorbid conditions, which can impact how healthy the liver is as we're treating the rheumatologic condition. Evaluate the impact of our treatments. We watch this dynamically over time, and this is something that we can intervene with. Treat if need be. We can treat comorbid conditions, and we can certainly now these days, even with viral hepatitis, very exciting that we can actually treat it. And we need to be aware of this. It's dynamic. We need to follow it over time and keep our patients safe. So a lot of excitement now in terms of the liver, and hopefully we can keep that happy as we treat our patients to remission with their rheumatoid arthritis and other autoimmune rheumatologic diseases. So thank you very much for listening on this Step Talk. This is for RheumNow Live 2025. This is Dr. Artie Kavanaugh. Thank you.